Thank you, Doctor, and thank you for this invitation from Saudi Arabia. Uh, I hope it's a light presentation after the dinner. So, could I start? So, I will brief about the migraine, then I will talk about the management. It's a brief presentation that will highlight or put spots only about management of migraine. In migraine, just remember the clinical history is everything, is totally everything. We will go through one case, and by that we could discover that how to diagnose migraine. So this is a patient with she's 35-year-old lady on case of headache. Basically, her headache is lasting for half a day, but sometimes get up to 2 days. She get like 3 to 5 attacks per month, especially premenstrually. Her headache is on the right side. It's thrombing in character, and most of the time it's moderate in severity. However, occasionally it can be severe. It's associated with photophobia, phonophobia, and blurring of visions, but no other manifestations. Upon systemic review, her examination were negative, and basically her neurological exam were normal. So this is very classical case of migraine that matching the criteria for migraine without aura, and by history, you could make the diagnosis of migraine. So diagnosis of migraine will depend on number of attacks required to diagnose migraine is 5 attacks, and just remember, headache migraine is lasting more than 4 hours. If it's less than 4 hours, consider another differential diagnosis. It needs to be essentially associated with 2 out of 4, which is unilateral, thrombing, moderate to severe, increased by physical activity. Also, it needs 1 out of 2 associated symptoms, including nausea and vomiting or photophobia, phonophobia. Definitely, there is no other diagnosis that can meet or fit for the diagnosis of migraine, then you can diagnose the patient with migraine. Migraine is so challenging in terms of diagnosis and in terms of management. It's not like simple as I mentioned. So, and it's a complex syndrome that starts with a pre-DROM, aura, then headache, and end with post-DROM. In pre-DROM, the patient will suffer from vague symptoms 1 or 2 days before the headache attack, including yawing, nausea, vomiting, feeling unwell, muscle ache. And in aura, it's just the symptoms that started before the headache. When the patient developed sensory symptoms or visual symptoms, few minutes before the true headache, as we describe it. And after the headache attack, the patient will develop post-DROM, will they suffer from mood disturbances and fatigue. Again, once you saw a patient with migraine, just remember to exclude other differential diagnoses. And sometimes we use like monomers to remember a red flag. And in this slide, we are just talking about SNOOP, which is like looking for systematic symptoms of fever, weight loss, also secondary causes if the patient has risk factor like HIV, if they have another neurological manifestations, onset, and the other stuff that just looking for secondary causes. And the top are infectious, malignancies, or hemorrhage. Also, cerebral venous thrombosis is one of major things that need to be ruled out, especially in a patient in ER. Just remember, a patient who presented to the ER, their approach of headache is stress on secondary causes, not like a patient who is in the clinic. Of course, remember, examine the patient well and don't forget to examine the fundus. Normal neurological exam without doing a fundus is incomplete exam and can lead to catastrophe. If we go back to migraine, migraine can be induced or aggravated by certain provocation, including stress, psychological problems, sleep disorders, certain food, or odors. Also can be related to weather or light exposure. This is a brief about diagnosis of migraine. If we are talking about management, we go in 3 lines of management, which is non-pharmacological treatment, then pharmacological, which acute, and preventive treatment. We will go to each one. We will start with non-pharmacological treatment. Usually you need to instruct your patient to go to a quiet place, dark, to improve quality around them. Keep hydration of the patient is very, very important, as dehydration, one of major things that could lead to aggravated migraine. Sometimes using also ice packing or creams containing menthol could improve the attack. However, these measures will not improve dramatically, but it could just help the patient. Most of the patients with migraine, they will require acute treatment management, and that to get pain freedom and restore their function. Also to avoid getting rescue of medications or visiting the ER, and that will add a burden to the hospital system. So acute treatment at home will improve the cost definitely. If we go back to our case, sometimes the severity can help you to decide which medication you elect. Our patient has moderate to severe headache, and based on that, you could classify your patient if they are mild or moderate. You could start with non-specific medications. Any painkiller can help you, starting from NSAIDs, including naproxen, Celebrex, ibuprofen, even paracetamol can help. However, if the migraine is moderate to severe, here you need specific medications that are designed for migraine, including triptanic groups, G-PANs, and D-TANs, which we will talk about it. So we classify medications to specific and non-specific, depend on severity. Also, you will treat it and you will elect. Of course, one of the major rules is to start the medication as early as possible. It's proven that early treatment of acute migraine attack will make it easier to be controlled, and if a patient neglects themselves for more than 2 hours, it will be challenged to control. However, most of the data from literature describing that 50% of the patients, they don't like to start the medication early, which makes their headache burden to them. Also, no single medication is correct for every patient. Every patient has his own condition that based on that condition, you elect the medication. And the best approach is a stratified care approach, which you sit with your patient and you look for the severity, duration, disability, timeline peak, and you decide from the same sitting about election of the medication based on that. You don't go on a stepwise approach. So you give your patient paracetamol, and next visit ibuprofen, and next visit naproxen, and then triptan. That will lead to worsening the outcome, and maybe they will go to medication overuse headache, which is more challenge for management. If we are talking about non-specific, top are NSAIDs, which is the first line for mild headache. However, keep in mind the risk of GI bleeding and medication overuse headache. Also, there is one trick about the ibuprofen versus naproxen. The ibuprofen will work fast, but not sustained. After 4 hours, it will disappear from blood and may require another dose. However, for naproxen, it works slowly, but the efficacy it could reach to 12 hours if the patient received around 500 milligram dose. So it can be used for these patients who migraine persists for longer duration. One of the specific medications is the triptan, which is selective 5-hydroxytryptamine agonist, specifically for B and D. Also, we have ergots, which is work in the same mechanism relatively, but in subtypes of receptors. The novel drugs is D-TAN, which is very selective medication. G-PANs, which is calcitonin gene-related peptide receptor antagonist. Also, we have a neuromodulator that we will come to it in detail. About triptan, is still considered as a first-line treatment, and it's available in oral, nasal, spray, and subcutaneous. And here is very important for the patient who develop nausea or vomiting to avoid non-oral medication to improve their adherence or selection, because if the patient is suffering from vomiting, he will not tolerate triptan. Triptan has many contraindications, including cerebrovascular or cardiovascular disease, peripheral vascular disease, hemiplegic migraine, and uncontrolled hypertension. This is because of risk of vasoconstriction. Although nowadays hemiplegic migraine is not considered truly absolute contraindication. It's well tolerated, but this group of patients, they cannot receive triptan, which makes the use is limited for them. Recently, we have new medications that approved, including Celebrex, Lazimtan, Remi G-bands, Europe G-bands, and remote electrical neuromodulations. One of mechanisms that was studied well is CGRP receptor antagonist, which work in different mechanisms for migraine. So activation of this receptor will work in central peripheral sensitization and vasodilatations, which is the major mechanisms in migraine. Interruption of this receptor will improve the migraine or stopping pain in one part, and also will work as a preventive treatment. From that side, G-PANS is playing a new role recently. This is the mechanism of migraine that we spoke about, and this is the different mechanisms, and you could recognize that CGRP is here, and their role is with G-PANS or Elaronimab. Many trials work in that part, honestly, since 1990. However, most of these trials failed because of liver disease impairment secondary as a side effect from these medications. However, these medications, some of them are monoclonal, which improve the quality of these medications and getting approval recently. Also, as we mentioned, the other mechanisms, which is 5-HT, including previously triptan and recently D-TANs. For D-TANs, it's a novel drug that proven by FDA in October 2019. It works through 5-HT, specifically for receptor subtypes F, and not work in or low affinity in subtypes P, which is leading to no vasoconstrictions, which is better in term compared to triptan group. It's a proven efficacy, including simidiltan, is proving double pain freedom compared to placebo, as you can see in this slide. It's indicated for patients who has triptan contraindication or failure to use triptan. Most of side effects are tolerable, however, it can lead to serotonin syndrome. The major restriction in D-TAN is driving issue. And remember, D-TAN and the driving has major issue and conflict, so it's supposed to avoid the driving after using D-TANs by 8 hours, and that's major limitations. However, it still can be used for people who get migraine in late of their day or before the sleep time. As we mentioned about the CGRP, that it works in many mechanisms, including central, peripheral, and vasodilatations, which is make it a good for pain control for migraine. So G-PANS is also recently approved in 2019 for Europe G-PANS, and for Remi G-PANS is approved in 2020. It works as antagonist for these receptors, and it showed good efficacy compared to placebo by improving pain by 50% for Europriptan and this Euro G-PANS, and this is same also for Remi G-PANS. It's indicated for migraine, and one of major advantage is not associated with medication overuse headache, which is compared to triptan has side effects. So that will improve or can be used for patients with medication overuse headache. It's well-tolerated medications, and however, it wasn't tested well for patients with cardiovascular disease, including stroke and MI. That make it limited, and we are waiting for emerging data if it can be used or not. It's can be used as BID medication for uritriptan or single per day for REMI GPANs. For remote electrical neuromodulations, it's proven recently by FDA. It's delivering transcutaneous electrical stimulation, which work as conditioned pain modulations. It's good tolerated and minimum side effect, including paresthesia only. However, it has restriction for patient who has arrhythmia, pacemakers, epilepsy, and for a pregnant lady or below 18. It wasn't approved for these groups. This is regarding the acute medications, and this is not the end of the story. Many patients will require the preventive treatment, as acute treatment will not be enough. Our patient is suffering from many attacks of headache, around 5 attacks monthly, and that will not suitable that she will be only depending on acute treatment or painkillers. And that's the aim of preventive treatment, which is reducing use of acute treatment that will improve also severity of the headache, duration or frequency, which will lead as impact for reducing the cost and improving life psychological stress for the patient. Election about the patient who are candidate for preventive treatment will be who are suffering from disabling attacks or medication overuse headache or failure of medications for acute treatment. Of course, if the patient has preference to use preventive treatment to avoid getting attacks of headache will be also acceptable option. And using preventive treatment don't depend on patient recall attacks, because if they attend to you in the same day that they have headache, it will be a bad about their month. Just depend on measures. And one of these basic measures is headache impact test. However, simply you can use headache diary, help your patient with headache diary that you could review it yourself rather than depend on your patient how many attacks and depend on their ability to recall. These are the medications that used for preventive treatment, and you can see from this slide, anti-epileptic antidepressants are on the top. However, back to CGRP, including inerimab and other group of monoclonal antibodies, are recently proven. For neurotoxins, Botox proven, I think, in 2010, if am I correct? However, again, for selection of preventive treatment, just look for the side effect, contraindication, and patient preference or comorbidities. Certain patients who are suffering from weight gain, you need to select for them medications that could reduce the weight or avoiding medications that cause weight gain, including dipakine. Patients who get exercise intolerance, avoid beta blocker for them and use Topamax or a fixer for them. For patients who are like suffering from renal stones, Topamax will be contraindicated for them. And of course, people who or ladies who are planning for pregnancy, propranolol will be considered as the safest drug among all of these groups. Sometimes comorbidities will help you, like for patients who are suffering from depression, selection of antidepressant will be helpful, like amitriptyline or a fixer. Who are suffering from anxiety, beta blocker can be helpful. Time's up.
Thank you, Dr. Mohammed, for this wonderful speech about headache. I know headache is a very interesting topic, and everybody will think about it.